My name is Kelsey, and I have type 1 narcolepsy, also known as narcolepsy with cataplexy. I'm not sure exactly when my symptoms first started, but I've always been described as not a morning person. And the reason I say not a morning person is that I'm also not a night owl. And I've always had great difficulty functioning in the morning, but I don't have a lot of energy at night. Rather, my sleep schedule was all over the place. Over the years, I tried many things to improve my sleep habits and become more of a morning person. I went to bed earlier. I took naps during the day. I went to the gym in the morning. I hired a trainer to meet me at the gym so that I'd have accountability to show up. I set multiple alarms. I took cold showers, biked to work, walked to work, but nothing seemed to work. So I just accepted that I wasn't a morning person. And since this was all I'd ever known, I thought all people who weren't morning people were experiencing the same things that I was. And I continued to try to begin my day at a reasonable hour as society expects. And I thought, well, if everybody else can do it, I should be able to do it too. I did continue to tell my doctor that I was often tired and had no energy, that I seemed to sleep a lot, but those symptoms can mean a number of things. And so I got the usual advice to eat better, exercise more, do yoga, stick to a sleep schedule, take vitamins, see a therapist for stress management, and the list goes on. I did all of those things and more, but despite that, my symptoms continued and compounded over the years as I went untreated. I first noticed cataplexy in my 20s, but I didn't recognize it for what it was. I also didn't make the connection that it was triggered by strong emotion because it wasn't just laughter that triggered it. It seemed to happen very randomly. Well, basically whenever I experienced a strong emotion, but I didn't make that connection. Rather, I thought there was something wrong with my knees because that's the main presentation was that my knees would buckle. And I mentioned it to my doctors, and they examined my knees and but never found anything wrong with it. So they just said, well, we'll monitor it. If it gets worse or whatever, we'll see if we can figure out what it is. I also didn't make the connection that cataplexy had anything to do with my sleepiness. And I didn't really have the words to properly describe how sleepy I was to my doctors. Rather than saying I had debilitating sleep inertia, because I've never heard of that term before, I was diagnosed, or excessive daytime sleepiness, I just said, I can't wake up in the mornings. I'm too tired to get out of bed, or I feel like I'm dragging my butt all morning. It takes me forever to wake up. And, it came to a point where I hit a wall and I just couldn't function enough to meet all my responsibilities. And so when doctors hear that, you have trouble getting out of bed, they first assume you're depressed and prescribed me an antidepressant, which just happened to be one of the first line treatments for narcolepsy at the time. It completely suppressed my cataplexy, probably delaying my diagnosis as a result. And I followed all of the treatment recommendations for depression, but my general symptoms of difficulty waking, being tired a lot, and sleeping a lot never went away. I kept telling my doctor regularly, I feel like I did when I had mono as a teenager. I'm sure that this is more than just depression. So they would run the blood panels for iron or thyroid or mono, but when they came back clear, they assumed that my depression was just not under control and increased my antidepressant. I was also regularly seeing a therapist to help manage those symptoms, and he was actually the first person to suggest that I might have a sleep disorder. I couldn't understand why he thought that. I thought I slept fine, just often and, at the drop of a hat. It took another 2 years from there to get a referral to a sleep specialist, and then I probably owed another year to actually get the full sleep study. So I was officially diagnosed with narcolepsy actually, I was diagnosed with either narcolepsy or idiopathic hypersomnia in late February of 2020 because I hadn't yet made that connection with cataplexy since it had been suppressed by my antidepressants. That was about 2 weeks before the whole world shut down. My sleep specialist suspected narcolepsy following the overnight polysomnogram, and I distinctly remember that first meeting with him where he said there's no cure for narcolepsy, but it is manageable with the right combination of treatment and dosage, and that once we find that right combination, I would feel better than I have in years. I thought it was going to be so easy. I thought that it would only take 6 months max to get this figured out, and that I would be as good as new and all my problems would be solved. What I didn't realize was how impactful some of the medications are for narcolepsy, both positively and negatively. That side effects are very common, and sometimes they can outweigh the benefits. And that some of the medications also have discontinuation effects, making medication trials more difficult. The medications are generally started at the smallest dosage, and then that dosage is slowly increased over time while monitoring how effective they are, what side effects they may be causing. Some medications can be stopped abruptly, others need to be decreased slowly over time, and it can take months to evaluate one medication. Some medications can be taken in combination, but then the side effects become more difficult to manage because it's not clear which medication may be causing which side effect, or if it's a combination of the medications that's causing some kind of interaction. I also didn't realize that treatment isn't just limited to medications. The symptoms of narcolepsy also need to be managed by lifestyle adaptations, such as practicing good sleep habits, getting regular exercise at the right time of the day, eliminating foods that make you sleepy, getting natural light early in the day, avoiding blue light in the evening, establishing consistent routines for waking, sleeping, eating, exercising, and napping. So not knowing that, I just continued on with my old habits of working late into the night, because that seemed to be when I was the most alert. Mornings were definitely not my time. I was started on methylphenidate, and there was some improvement, but not the improvement that I needed to stay on top of my law practice. So then I tried modafinil, and although this drug works well for many people, it didn't do much for me other than add some more side effects. So after several months, I went back on the methylphenidate, and then I tried, without success, mixed smaller doses of modafinil with the methylphenidate, before eventually trying lisdexamfetamine. This worked a lot better for me, but it ended up keeping me up very late at night, and that would just compound the sleepiness in the morning and made things harder for me in the end. So eventually I tried sodium oxybate, which is a controlled substance and is handled by a central pharmacy rather than your regular pharmacy system. And you need to enroll in a patient monitoring program in order to qualify for it. It also requires special authorization from most health insurances. And so I was starting the sodium oxybate, because you have to titrate up on that, while still taking the lisdexamfetamine and still on antidepressants, and noticed that my Raynaud's symptoms were worsening. And so I made several medication changes trying to find the culprit, what was causing that, and decided that I wanted to eliminate my antidepressant from the side effect equation and wean myself off of that, even though I was still in the process of increasing the sodium oxybate dosage. Unfortunately, making all of those medication changes at the same time caused a number of side effects and or possibly discontinuation symptoms. I can't say what was what, but it wasn't pleasant. I couldn't focus, I couldn't concentrate, my anxiety levels went through the roof, my mood was affected. I had to stop the antidepressant discontinuation and build back up to my maintenance dose and wait for those symptoms to dissipate. And then I was eventually able to discontinue that medication when I did it at a much slower rate. In the end, I ended up stopping all of my medications, including the narcolepsy ones, stopping work, taking a 3-month break, and starting from scratch, one medication at a time at the lowest possible dose until I found something that helped. Being home alone during the pandemic, I also didn't have anyone to talk to about my symptoms or the various medications I tried. And I tried them all, including amphetamine and pitolisant. Nor did I have any objective observer to point out behavior changes or reactions that I might have been having to the meds. So we're not always our best objective observer when it comes to behavioral changes. And it wasn't until I discovered the Wake Up Narcolepsy online support groups that I met other people with narcolepsy and found a community of people who understood my symptoms and challenges. I also realized that not everyone has the same symptoms or severity of symptoms or responds to meds in the same way. Each person with narcolepsy is a unique individual with a different physiology. They have different comorbidities, different levels of support from family, friends, and medical providers. Life factors such as stress, loss, grief, and for women in particular, changes in hormonal cycles all impact symptom severity and how a person with narcolepsy responds to treatment. But the support groups gave me hope and solutions. I felt more engaged in my treatment. They taught me that people with narcolepsy are tough and resilient, that very few people realize how hard it is to live with this disorder, and nor do they realize, what a person with narcolepsy actually experiences day to day. The support groups also helped me realize that I was relying on the medications to do all of the work and that I needed to make changes to my lifestyle to help optimize the meds and better manage my symptoms. I needed to not just address the sleepiness, but also the disrupted nighttime sleep. I needed to not just treat my narcolepsy symptoms, but any and all health issues. I can't eliminate narcolepsy from my life, but improving my overall health can lessen the impact of my narcolepsy symptoms on my daily life. And that was a hard lesson to learn. Living with narcolepsy is a journey, and getting the diagnosis is just one step on the journey. Part of the journey is also grieving the loss of the life that I thought that I would have. And I can make that harder by fighting it every step of the way, or easier by accepting it for what it is, that there's going to be good days and bad days and bumps and obstacles along the way. But the grieving process isn't linear. It's not a one and done process. I need to give myself time, grace, and compassion to focus on the goal of being as healthy and well as I can be. But I don't want anyone to think that I've got it all figured out. I'm still learning about the disorder and how to live with it. Narcolepsy is hard. It can be managed with a combination of medication and lifestyle changes, but those take time to put in place and to calibrate. Also, knowing what to do and doing it are two different things, especially when, the symptoms of narcolepsy make it so hard to focus, maintain motivation, and find the energy to get through a day. So my key takeaways from my journey so far is that brain engagement is key. If I'm interested, engaged, focused on the task at hand, I stay alert and awake. If not, I'm fighting sleep or sleeping. And stress and anxiety only make my symptoms worse. So listening to my body, taking a break when I need to, generally leads to a better outcome than trying to push through the fatigue or brain fog or trying to fit more into a day than is realistic for me. So my mantra has become, I can do anything, but I can't do everything. And so I'm hoping that I'll be able to pass some of those lessons on to people listening today. That's the end of my presentation.
Thanks, Kelsey. That was really wonderful to hear your story. I'm very sorry to hear that that's what you've gone through. And it's very inspirational to hear sort of how much you've done for yourself and the amount that you've been able to be involved in your own care and have taken control of your symptoms and really, really great to hear your journey, and very thankful for you providing that story to help others, because you have so many salient points there and so many wonderful lessons that I think many people can benefit from. So thank you so much for sharing that. Hi, everyone. I'm Dr. Laurel Charlesworth. I'm a sleep neurologist at the Ottawa Hospital. And so I've been asked to talk about narcolepsy medications. And when we first met to talk about how to put together this webinar, we had discussed whether Kelsey's story would come first or second. And I just think it's so helpful for, as Kelsey was saying, for people with narcolepsy who have some shared experiences, maybe not the same experience, but shared experiences, to have that resource with each other. Because when it comes to any chronic condition, including narcolepsy, sometimes people end up being their own expert of the condition. It's always great if you have a physician who really understands the condition, but that's not always the case. And so sometimes patients have a little bit of an extra role in advocacy, or even if you have somebody who really understands the condition well, it doesn't mean that they know exactly your experience and you become the expert in your own health. And so really understanding the roles of different parts of treatment, whether it's medications or lifestyle interventions, can really help with the management journey with narcolepsy. So I'm hoping that this will give some extra information in your pocket, whether it's you yourself who have narcolepsy watching this presentation, or a loved one, or simply you're just hoping to learn more about the condition. I hope that this is helpful. So a couple notes: I will only be using generic names of medications. So no brand names in this presentation. And then secondly, as has been stated on several occasions, this narcolepsy is such a individual, a personal experience to each person who has the condition. And so this is a general approach, and not intended as medical advice, more just knowledge in your pocket. And so some things may resonate, some things may not, and that's okay. We're going to start briefly by talking about physiology of narcolepsy and the sleep-wake system, because a lot of the medications directly impact the physiology. We'll talk about the major symptoms being hypersomnolence and cataplexy, and then talk about how the medications can benefit those symptoms or manage those symptoms, and then finally discuss the role of non-pharmacologic management as well. So there's very complex wake promoting systems in the brain. The very center of this is really the brain stem and the deep centers of the brain that expand through the wakefulness and reward pathways. And so the key neurotransmitters here are norepinephrine, dopamine, serotonin, and histamine. And so when we're talking about the medications, you'll hear a lot of these coming up, because these are the targets of the medication. The real sort of star of the show is orexin, which is a tiny little hormone that basically acts, essentially, I like to think of it like a teeter-totter, and it's like that piece in the middle of the teeter-totter that helps to stabilize things. And narcolepsy is sometimes a bit misunderstood in that people think it's a sleeping problem. But it's not a sleeping problem. It's a sleep-wake stabilization problem. And it really comes down to that stabilization of sleep and wake states. The engineering term for this is a flip-flop switch, meaning a light can't be on and off at the same time. And the way the brain is wired, you're not supposed to be able to be asleep and awake at the same time. And that's where orexin comes into things. But when the orexin system is not working properly, then people can flip and flop in and out of sleep, and sometimes is the crux of narcolepsy. There are two types of narcolepsy. Type 1 narcolepsy is narcolepsy with cataplexy, and it's defined by low cerebrospinal fluid levels of this hormone orexin, whereas type 2 is narcolepsy without cataplexy. Both types of narcolepsy have hypersomnolence or excessive daytime sleepiness as a common symptom. There are REM intrusions, commonly sleep paralysis or hypnagogic hallucinations as people are falling asleep, and sleep-wake instability. So both sleep intruding into wake, but also wake intruding into sleep. So with that, we'll move into the symptoms. So hypersomnolence, this daytime sleepiness, is a common symptom of narcolepsy. As almost everyone who has narcolepsy will experience a level of excessive daytime sleepiness, although it is variable person to person. And this is trouble with that flip-flop sleep-wake switch. This is essentially the most common symptom that we're targeting when we treat with medications. And I think it's likely because it's the one that is the most prominent in terms of functioning. So it's the one that usually brings people to medical attention. Cataplexy is seen in patients with type 1 narcolepsy. It's the defining feature. And so when you're asleep and when you're dreaming, your spinal cord is paralyzed so that you don't thrash and act out your dreams. But in narcolepsy, because sleep and wake are not mutually exclusive, sometimes what will happen is that paralyzing function of the spinal cord will occur when it's not supposed to, and then people will become briefly paralyzed, whether it's the full body or just parts of the body. As Kelsey was saying, sometimes the knees will buckle. I have some patients where they will just become a little bit slack-jawed, or sometimes it'll just be an arm or a leg. And so these symptoms can present differently in everyone. There are additional symptoms as well that are sometimes less acknowledged. So weight troubles are very common among people with narcolepsy, especially in the pediatric population. That tiny hormone orexin and that system there is involved in weight management and appetite control as well. So very often people, when they newly present with narcolepsy, can also have quite substantial weight changes, usually weight gain, around the time of diagnosis due to those changing hormonal systems involved in appetite and hunger. Chronic pain is very common among people with narcolepsy, and there have been some studies that have demonstrated decreased pain threshold. Sleep is so important in the manifestation of pain and the brain's ability to cope with pain. And so chronic pain syndromes, including migraine or fibromyalgia, can be more common among people with narcolepsy. Mood disorders like depression and anxiety are common. And it's not entirely clear if this is due to the condition itself or because of the lower awareness, the delayed time to diagnosis, and all the socioeconomic impacts of having a chronic condition like narcolepsy. Regardless, it is can be a shared experience among people with narcolepsy, and it's important to acknowledge. And then finally, other sleep disorders very commonly come along with narcolepsy. Sleep apnea, especially as people get older, it's very common in the general population and even more so among people with narcolepsy and insomnia as well. So really, the bulk of this talk, we're going to talk about the medications. So starting with medications that really try to address the symptom of daytime sleepiness, the symptom of hypersomnolence. So we'll talk about modafinil and the stimulants, methylphenidate, dextroamphetamine, lisdexamfetamine. And there are two newer medications. I don't know if they quite warrant the starburst new anymore because they're a couple years old. But solriamfetol and pitolisant, it was reasonably exciting when they came out because they were the first new ones in a while. So we'll also discuss these. Starting with modafinil, this produces an elevated level of alertness by multiple neurotransmitter pathways, especially serotonin and dopamine. It tends to be a highly effective medication, although, as Kelsey pointed out, very variable among people. Some patients respond really well to this at a lower dose. Some people do really well at a higher dose, and some people don't respond quite as much as well. And that really speaks to the individualized neurotransmitters and brain systems. It isn't a stimulant per se, but it can provide sort of some types of stimulant experiences among people. The tablets are in 100 and 200 milligrams, and they're taken 1 to 2 times per day. It takes about 2 hours to take effect, and it can take a little bit longer if it's taken with food. It takes a bit longer to be absorbed. So for a quicker onset, it's best to take it on an empty stomach, and it lasts about 8 hours. Because a generic form is available, it is not overly costly, about $1 per pill, depending on your pharmacy and depending on your pharmacy fees. There are some prominent side effects, and these kind of overlap with a lot of these medications. So headache, sometimes nausea or decreased appetite and insomnia. And more common in kids, although can be present in adults, is a severe rash as well, or even a syndrome called Stevens-Johnson syndrome, which is a medical emergency. So rash, we always warn people to watch out for that. The other very important note about modafinil is that family planning is very important with this. So it interacts with oral contraceptive medications to decrease the efficacy. And it has been shown to have at least some level of teratogenicity, meaning that it can affect a developing fetus. And so if a patient who could become pregnant is taking modafinil, then it's important to have backup forms of birth control that are not hormonal. So for example, an IUD or barrier contraception. It's not incredibly well known exactly modafinil and depot as a newer form, but generally recommended against. So important to talk with your doctor about that. The next class of medication is stimulants. So these are methylphenidate, dextroamphetamine, lisdexamfetamine, sort of as a class of medication. These are widely available in generic form, so generally more affordable, on the scale of well less than $1 per tablet. And they're available in immediate and controlled release forms, so the longer release or the shorter release. And this is really helpful because the shorter release means that there's a lot more individualization that can happen. And when we talk about combining medications, at least my own practice is usually having an element of an as needed add-on medication for those times when a little bit of extra alertness is required. These are controlled substances, so the prescriptions have to be written in a very particular way, and you may be a bit more restricted when filling the prescriptions in terms of the time frame. There is theoretically an abuse potential for these medications. In general, people with narcolepsy do not get into that cycle because it's being used for wake promoting. But because of this and in other populations, we do have to be quite careful about the doses that people are not requiring higher and higher doses. Side effects are quite common with these medications, especially at higher doses, and truly often patients with narcolepsy may require those higher doses. So decreased appetite is very common, headaches, anxiety, palpitations, or elevated blood pressure. The immediate versus continuous release is good to know about the difference, and we will often use these in combination. Immediate release tends to be a little bit less expensive. It is quick onset, generally onset within 30 minutes, an hour, and lasts that short period of time. But because it's a quick on, it's also a quick off, and so it can lead to a crash. So the role of the immediate release in therapy is often for that, okay, it's, 3 p.m., it's too late to take a modafinil, but I really need to be present for my kids' hockey practice. I really want to be able to sit in the stands and watch them out there, but I find it a little bit boring, and I don't want to fall asleep. Maybe that's a great time to take an immediate release stimulant medication, whereas the controlled release or continuous not continuous release, controlled release has a bit of a more prolonged effect, less of a crash, but not great to take close to bedtime because it really can affect sleep quality. These newer options are pitolisant, so it's a new mechanism. All of these others have been norepinephrine, dopamine, serotonin. This is by the histamine system, and it's the only medication, at least so far, that works by this system. It is on label for both hypersomnolence and cataplexy. It takes effect relatively quickly, about 2 to 5 hours, and it's pretty long lasting, so it's usually just once a day dosing. Because it is a new medication, it is relatively expensive, depending on where you fill it, about $500 a month for a single tablet. But the smaller doses and the larger doses, I just called the pharmacy to confirm, at least here in Ontario, are the same price. So sometimes a higher dose does not necessarily mean that you're paying more. It does interact with other medications, including birth control. So similar to modafinil, where it lowers the efficacy, pitolisant seems to lower the efficacy as well. There are side effects very similar to the other medications that we talked about, headaches, anxiety, and palpitations, among others. And it's a newer medication, so we are still learning about the less common side effects that people may experience. Solriamfetol as well is a new one. It is a bit of a mouthful, but quite fun to say once you get it. It is a alertness promoting medication working via the dopamine and norepinephrine systems. Takes effect relatively quickly, lasts a mid portion of the day, and it seems to be a very good option. It is a similar price point to pitolisant, again, because it's a newer medication, tends to be a little bit more expensive. It doesn't interact with many other medications, although there are some cautions. So anything that elevates blood pressure, because high blood pressure can be a side effect of this medication, must be carefully monitored. So the big ones here are dopamine agonists, like pramipexole, for example, for restless legs. And herbal products. This is something that is often thought of a little bit less from people about these over-the-counter medications. They actually can interact. So ginseng, arnica, ephedra, and licorice, if you particularly like your black licorice, can interact with this medication and cause elevated blood pressure and some complications, higher level of side effects. So important to know about. So those are the medications that really mainly address the hypersomnolence or the sleepiness. So now there are some medications as well that help specifically with cataplexy in patients with type 1 narcolepsy. As I mentioned, cataplexy is an inappropriately timed spinal cord paralysis, and it is normal physiology. It is a normal thing that happens. It just happens at the wrong time. It's usually triggered by strong emotions, as Kelsey had mentioned in her experience. Sometimes it is mirth, it's laughter, it's something that's hilarious. And sometimes it's anger, sometimes it's surprise. So really anything that triggers that high level of emotion can trigger cataplexy. The one of the strongest stimulus for a lot of people is less about somebody making you laugh and more about you're about to tell a joke. That moment where you're like, oh, this is so funny. Everyone's gonna, oh, this is great. That tends to be one of the biggest stimulus for people to have a cataplexy attack triggered. So there are different classes that help with this: SSRIs and SNRIs, venlafaxine, duloxetine, fluoxetine, tricyclic antidepressants like clomipramine and imipramine, and then others like sodium oxybate and pitolisant. So antidepressants can work well. They suppress REM sleep, so they suppress that inappropriate activation, essentially, of the that descending inhibitory signal. These tend to be the most commonly used, and they are the first line treatment because they are the best tolerated usually. They also have additional benefit to help anxiety and or depression. They aren't without side effects. So the most common side effects that people can notice are sexual side effects, whether it's libido or troubles maintaining erection in male patients. Dizziness, sleep disruption can be a side effect, particularly important to consider in patients with narcolepsy. And that can take the form of either sometimes a little bit of extra energy where it's more trouble getting to sleep at night, and sometimes a little bit more of insomnia. Tricyclic antidepressants are also a class of antidepressant, and examples of these are clomipramine and imipramine. These medications are really effective. However, we often use them as second line because they can have potent side effects, the strong ones being dry mouth, constipation, drowsiness, again, not something that you would necessarily want to add on for a person with narcolepsy. And in patients who get to be a little bit more elderly, above the age of about 70, you get more concerned about possibly causing confusion as well. So mixed salt oxybate and sodium oxybate are medications that are on label for both hypersomnolence and cataplexy. These are really effective medications. We don't know the exact mechanism, but it essentially works by consolidating nocturnal sleep. And so not only does it help with that sleep fragmentation, which is wake intruding into sleep, it can also help with daytime sleepiness, sleep intruding into wake. So it really kind of helps to stabilize the sleep-wake rhythms. As Kelsey mentioned, it's highly regulated, so it can require a couple of extra checks and balances to acquire the prescription. It does come from a central pharmacy, and it does require both you and your physician to have gone through learning material, and you have to provide documentation that you've done this learning material. It is a liquid, and the sodium oxybate is really quite salty, and so some patients are not particular fans of that level of saltiness. It can be a little bit not the best experience. However, the newer mixed salt oxybates are much of a less salty medication, and that's newly available in Canada. I think it was approved midpoint just last year and newly now available to be prescribed, I think, in the autumn of 2023. So that's a great option if the salt is not the best experience for the person. It is dosed immediately before bedtime, and then there's a second dose after 4 hours. So usually the person will set an alarm or have somebody wake them up. There are some troubles with access to this medication and troubles that may prohibit patients from using this. So the first is it can be expensive, although there are some medication programs that will help to cover this medication. So if it's something that you're interested in, you can always talk to your doctor about that. There are some safety considerations in that people are very sedated with this medication. There are some more recent studies that suggest that the arousal threshold, meaning the level of stimulus required to wake somebody up, although it is higher, is still within a safe realm. So, when I was going through training, one of the things that I was always cautioned to talk to patients about is if the fire alarm goes off, you might not be able to wake up and get yourself out of the house, which of course is a very scary thing to think about. So it was always cautioned, you only provide this medication if somebody lives with somebody who can help them out in the case of an emergency or an intruder or whatever it may be. There are some newer small studies that suggest that that might be less of a concern than we thought, but there's a little bit more, I think we need a bit more evidence for that to say definitively from a safety perspective. It can be more troublesome to use this medication with medical comorbidities that prohibit high salt content, like heart conditions or kidney conditions. The mixed salt oxybate is less of a problem for this consideration. The main side effects are tremor, dizziness, sleepwalking and sleep eating, and rarely bedwetting as well. So it is quite a strong medication with potential side effects, but can be really, really effective. And it's particularly good for the combination of hypersomnolence and cataplexy, and also one of the medications to strongly consider if fragmented sleep is a major problem for the patient. There are new medications in the pipelines. So there's a new formulation of methylphenidate that was recently available in the United States. So this is an evening dose of methylphenidate that releases slowly and then essentially is in effect by the time the person wakes up. This is not yet available in Canada. There is a new formulation of sodium oxybate that is once nightly dosing instead of having to set that 4-hour alarm. Again, available in the States, not yet available in Canada, but medications do often make their way up here shortly after. And then there are some exciting new options that continue to be in development, like the orexin agonists. So these are ones that really kind of target that the real crux of the issue in narcolepsy. So that will be exciting when these come to market. And so I'm just going to check the time. So we're at 14:40. So a brief note on lifestyle considerations. As Kelsey mentioned, this can be something that really supplements the pharmacologic management well. I think that I really want to put emphasis on this, that truly it is so individualized. And I find that in the first meeting, sometimes the second and third meetings with my patients, it takes a little bit of time to really encourage people that you and your physician are a team on this. It's a little bit different than some areas of medicine where it's a little bit more of a paternalistic approach, where you get a prescription, you take your medication at this time and at this time. Really, this should be a discussion between you and your physician to find what works best for you. And it may be different, for example, on your weekends versus weekdays. It may be different at different points in your menstrual cycle. It may be different at different seasons. And that's okay. And it takes a little bit of time to really get to know yourself with that. And the way I view the role of the physician is to help guide you with that, give you the parameters of sort of, here's what we're working with. And within this realm, this dose, this schedule, here's the ways that you can adjust. So getting used to your routine, and so having a nice routine, a more stabilized routine, can be really helpful when you're thinking about when to dose the medications. It can be beneficial. So for example, knowing when in the morning and when in the afternoon is too early or too late to take your medications, knowing when that as needed medication might be the better thing to go to versus a longer acting, and really kind of optimizing that in discussion with your physician tends to be an effective way to go forward. It's important to make these adjustments slowly because sometimes we can overshoot or undershoot. So adjusting one thing at a time is generally the best way to find the combination and the schedule that works for you. It's also important to use these medications in combination with lifestyle considerations. When it comes to pregnancy and medications, almost all of these medications are at least category C, which means that there's some evidence of potential harm in fetal development in animal studies. We don't have much evidence in human studies. Some of the newer ones, like pitolisant and solriamfetol, it's more in that unknown risk category. If they are newer, we have registered. I say we, I'm not involved in this at all, but there are registries to follow these medications and determine a bit more about the risk profile. It's very important to note, as I mentioned already, that some of these medications can lower the efficacy of hormonal birth control. So really important to consider that if pregnancy is not on the horizon, that backup methods are used. And so really important to discuss with your prescribing physician if you are thinking of becoming pregnant, and really making a personal choice. So some of these medications, there could be some discussing with your physicians the level of evidence that there may be very minimal side effects on the fetus, and the impact of being tired and not being able to do your day-to-day activity would actually be more damage than taking them. Not damage, I apologize. More negative than taking the medication. So really, really a personal decision is what I'm getting at with this. As people get older, medications change. The medications with narcolepsy can interact with other medications, so always important to review these with a pharmacist or with your doctor. Medications can build up in side effects as the kidney and liver function changes as we get older, and so that can cause accumulation of medications, and so the doses may need to be adjusted as we get older. And then oftentimes comorbid sleeping conditions in the general population become more common as we get older, and it's no exception in narcolepsy. So if all of a sudden symptoms seem to build up, it may not be the narcolepsy, it might be a new diagnosis, such as sleep apnea, for example. Some common, I've put mistakes in quotations here, more so cautions to mention. Travel is really important to consider with your medications. So filling prescriptions well in advance, especially stimulants where there is particular restrictions on when the medications can be filled. Some of these medications are also regulated in other countries, especially I recently learned in Japan. You can bring the medications in, but you need to do paperwork ahead of time. So it's important to look at the local regulations. Underemphasis on lifestyle adjustments can be sort of a common mistake heading into things, or on the flip side of that, overemphasis on medication and over-reliance on substances, including the pharmacologic medications and things like caffeine, at the expense of nocturnal sleep. And people can really get themselves into this negative feedback cycle where they're trying to stimulate themselves more to keep awake in the day and having much more challenging sleep at night. Commonly, people may not realize that there are some other symptoms of narcolepsy, like hypnagogic hallucinations, like sleep paralysis, can be very troubling, like fragmented sleep. We really focus on the hypersomnolence, but it may be that trouble getting and staying asleep that's more troubling to the patient. And so because hypersomnolence is what we see, sometimes it can be what we emphasize. But it's important to remember that there are other symptoms of narcolepsy, and a lot of these can be managed. And then the final caution to mention is medication safety. A lot of these medications can be troublesome if taken in very high doses. So just making sure that a child-proof lock is on the top and that they're in an appropriately stored area. Some lifestyle medications, lifestyle considerations are support truly the most important. Groups like Wake Up Narcolepsy support groups are so such an important part of the journey with a condition like narcolepsy. And it can be so helpful to hear about other people's shared experiences. Having supports from family, friends, and other people who have gone through similar things is very helpful. Maintaining physical health with regular activity, healthy diet, and it can be a bit more challenging to maintain weight with this condition because of those hormonal feedback loops. And so keeping in mind that that sometimes lifestyle measures can help. Sometimes you need some extra help from healthcare professionals, and that's okay. So discussing that with your family doctor or primary care practitioner can be an important part of the lifestyle management. Keeping in mind other mood disorders, chronic pain cycles, and things that can come along with narcolepsy, and treating these because pain and mood and everything can really affect daytime somnolence and those symptoms of narcolepsy as well. So treating these comorbidities can be important. Planned daytime naps and building a schedule around narcolepsy can really synergize with the medications and reduce the need for those pharmacologic means. And to that end, having accommodations in the workplace or at school can be very helpful. This is one of the first things I try to address with my patients is what can we do to help your day to day? And so bring that up with your family physician or with your sleep physician, because sometimes all it takes is a note for school or for work to really allow those small changes that can make a world of difference. Always important to protect nocturnal sleep, follow sleep hygiene measures, ensure sufficient sleep is attained at night to help with the daytime symptoms as well. I'm a little over time. I apologize. Thank you so much, everyone, for your attention, and happy to take some questions now. I wonder if I pull up the Q&A, I don't know if it shows up on the screen, so this may be blocking my
If you want to stop sharing, then
Oh,
you should
that's
be
good.
good.
I could do that. Yeah. There.
That's what I'm here for.
Thanks. Okay. All right. So I've got the Q&A up here. Okay, and I'll just note there are a couple questions in here about specific areas of Canada. I won't be making any comments on specific providers, specific brand name medications or things like that. But I think that that's one of the things that connecting with others in your area can be helpful for. There's a question here that says, what can be done with chronic pain issues in type 1 narcolepsy to help? So it depends a little bit on the type of pain that's experienced. Essentially, you would address the pain from the basis of those conditions. So, for example, as a neurologist, I see a lot of patients with migraine. So if I have a patient with narcolepsy and with migraine, I will follow the treatment approach as I would with somebody without narcolepsy in migraine. So typical first, second, third line medications. And so it doesn't change the clinical approach, but more so, I think it's important to just to be aware that these conditions can be troublesome and can impact and almost build on the symptoms of narcolepsy. So treating both together can be important. So whether it's migraine and talking with your family doctor or a neurologist about that, or fibromyalgia, talking with a chronic pain specialist about that, and choosing medications when possible that synergize. For example, duloxetine can be a good medication for chronic pain and also helps cataplexy in narcolepsy. So sometimes choosing medications that help both can be beneficial.
If I could just interject on that, I had chronic migraines for years, and it wasn't until I started getting treated for narcolepsy that I saw some relief, and it wasn't like I had been treated for the migraines, but I couldn't seem to get them under control. So I think there can be a link between not having your narcolepsy symptoms well managed and having the migraines, because they're lessened considerably. I know what the triggers are now, and if I get one a month or one every 2 months, that's significant now, whereas I was getting them every week, sometimes multiple times a week before. So I think the chronic sleep deprivation and all the other things that go along with narcolepsy can really make that worse. And so in addition to seeking treatment for it, getting your narcolepsy symptoms better managed can help with the chronic pain issues as well, for certain chronic pains.
Absolutely. That's a great point, Kelsey. We know even in the general population and people without narcolepsy, poor sleep lowers pain thresholds. So it's extra so when the narcolepsy is not well controlled with those symptoms. And this is my area of interest, is the overlap of chronic neurologic conditions with with sleep conditions. So we get that a lot, is these overlaps, and so managing them, kind of considering that both need to be managed to improve both, because migraines can make you sleepy, poor sleep can make your migraines worse. So it's just this feedback cycle, and important to address them both together. And happy to hear that your outcome from that was positive. Okay, the next is a comment about information about chronic pain with narcolepsy to forward to the patient's neurologist, who said there was no association with narcolepsy and chronic pain. So that's something I think that that's a bit more of a personal question. I think that that discussing that with them openly, that there are some feedback loops, and seeing if there's any suggestions that they have. I think that really focusing on, maybe this some physicians aren't as comfortable or aren't as familiar with treating chronic pain, or they've decided that that's separate from their scope of practice, which is very reasonable. It is a very large scope. And so separating those things, sometimes seeing somebody specifically for the pain separately would be reasonable. Generally in neurology, aside from migraines, it's not something that we treat. So sometimes seeking help from a separate specialty who specializes in pain may be beneficial. The next question, is there a length of time that somebody should take sodium oxybate? No, as much time as it is beneficial. There's, as far as I know, there's no evidence that long-term use will affect somebody negatively. So it really is, it's a symptomatic medication. If it's still helping, it's very reasonable to keep taking it. Somebody asked, how does the effectiveness of the mixed salt sodium oxybate compare to sodium oxybate? They're essentially the same. So the salt component is not the pharmacologic component. So what they've changed is the binding, not the actual medication. So as far as I know, it's a very simple switch. The efficacy is very comparable, is my understanding. But you can certainly speak with your prescribing physician, and everyone does react a little bit differently. So sometimes, for unknown reasons, even if pharmacologically we tell you one thing, if you experience another, it doesn't mean it's invalid.
If I can interject on that as well, just from my experience with the support groups, there's a lot of people who have switched between the various sodium oxybates, either for insurance reasons or other reasons. And for some people, it is exactly the same, but some people do respond differently. There's a lot of people with narcolepsy who POTS as a comorbidity, and they seem to respond much better to the regular sodium oxybate than the mixed salt ones. But then there's other people who have high blood pressure, cardiology issues, and they respond much better to the mixed salt. So those are things that you can discuss with your doctor. But and if one doesn't work, doesn't mean the other one won't, or vice versa.
The next question is about breastfeeding. Is the risk of taking medications when breastfeeding the same as pregnancy, where most available medications are seen as a risk? It's individual to each medication, and some of the medications we don't know incredibly well just because they're newer. But generally, the risk is more with the development of the fetus. I don't have the numbers off the top of my head. Some of them do can be passed along to baby through breast milk, but at a much, much, much lower concentration. So it is very individual to each medication. So it's important to discuss with the prescribing physician. But in general, it's seen as usually much of a safer approach. And really, that's when you really need those medications, is when baby is breastfeeding. Baby sleep cycles are all over the place, and really being alert when you need to be alert is important. So symptom management is so important in those times, especially. So in general, when talking about the risk and benefit, it usually heavily weighs on the benefit, but very individual to each medication, and a little bit more on those as needed medications, as opposed to something, for example, like sodium oxybate. I have a very quick answer to the next one, which is, any guesses on when the single dose sodium oxybate will be available? Unfortunately not. I have no insider information. Things in Canada sometimes lag behind the States by many, many, many years, and sometimes it's very quick. So we're always hopeful it will be quick. We'll see what happens. Okay. Oh, I will. This is a quick question that the answer is I don't know. Is the process for getting sodium oxybate the same for somebody with permanent residence in Canada versus somebody on a work visa? I'm sorry, I do not know. I expect it would be similar. And you could certainly talk to the family physician, the prescribing physician. I don't foresee any issues. They do have great patient handouts and patient education, so they would be able to go through that with you. Okay. There's a question about how to counsel patients on long-term, oh, it just jumped around. There we go. On long-term remission and trajectory of the condition. And this is a little bit outside of the scope of the talk today, but I think it's a very good question because that will affect the management and the pharmacologic management. And it's so individual to the person. I have patients who have gone into essentially remission where their symptoms are minimally bothersome for 20 years, and then for unknown reasons, they come back. And so that really is where it comes down to that knowing your body well and knowing sort of your symptom profile. Some people wax and wane, and some people never wax or wane, and they're really quite stable. We don't exactly know why that is. So it's really having that personal knowledge of your own symptoms. And there's no sort of a natural history type of progression that is well identified in this condition. In general, it does not spontaneously go into remission like some other sleep conditions, central disorders of hypersomnolence, like idiopathic hypersomnia, which can. Narcolepsy tends to be something that people have for their life, although can wax and wane. Okay. A lot more questions about the pain. I think we will move on from those questions just for the sake of time. I will comment that knowing that there's association can be helpful, and just target both the treatment of the pain and the narcolepsy can be beneficial, and talk to your local doctor or your personal doctor about that further. Any resources to share with a family doctor about narcolepsy? So resources like Wake Up Narcolepsy are excellent. There are evidence-based resources online, like Up to Date is the very common one that is used in the medical community, that has sort of Q&As there. There are some really good, depending on where in Canada you are, there are some good virtual options between physicians. So for example, here in Ontario, we have something called e-consult. And so essentially a family doctor or any other specialist can email me or email any sleep doctor with a link to the patient's chart in a confidential way, and receive answers like that. So e-consult can be a really good way to help spread awareness, especially if you're in an area that doesn't have a sleep specialist, for example. So that can be a really good way to access information. I believe that other provinces have these types of e-consult platforms. I'm just not sure what they're called, and encouraging discussion between specialties as well. I often get phone calls or messages from other providers just asking questions. Always happy to share information. And then the last question is a question about baclofen being used to help with sleep consolidation as an affordable alternative to sodium oxybate. Is that an option in Canada? Baclofen is a medication in Canada. It's available. There is no evidence specific to narcolepsy, and it works by a completely different mechanism from sodium oxybate. It is a sedative, and in general, sedatives themselves are not great among patients with narcolepsy. Everyone does react a little bit differently, but it certainly would be off-label, and as far as I know, there's no definitive evidence, and it works by a very different mechanism. So baclofen generally is not something that would be used in the place of sodium oxybate. And there's no other questions.
Thank you. That was kind of rapid fire. You did an amazing job. Thank you. Thank you both for this wonderful presentation. We learned a lot, and as mentioned in the chat, this recording will be made available later for any reference that you were looking for. So thank you again. And I want to thank our sponsors for enabling Wake Up Narcolepsy to bring the Brown Bag webinar series to the community. Thank you to our Diamond Champion sponsor, Jazz Pharmaceuticals, Gold Champion sponsor, Avadel Pharmaceuticals, Silver Champion sponsor, Harmony Biosciences, and program sponsors, Takeda Pharmaceuticals and Paladin Labs. Thank you, everyone, and have a wonderful day.